Oh, there it goes.
Yay! Hey guys, we're live with the total, oh my gosh, I can't even talk today. The Transitional Care Unit at Russell Medical Center. I was going to say total healthcare because total healthcare is always on my brain. I'm Kelly Adams with Beyond Home Care, and I've got Stephanie Jones, who's the coordinator of the Transitional Care Unit, and she is joining us today to talk everything rehab. So it's Rehab Awareness Week, and I know that for a lot of our clients, they have tons of questions about rehab and what rehab is and what it means and, you know, just everything. And so, Stephanie, tell us who you have brought along to talk a little bit about rehab, especially at Russell Medical.
Sure. So celebrate Rehab Week. We have Bailey, who is a physical therapist with us, and Kelly, who's an occupational therapist.
Awesome.
We all work with the Transitional Care Unit here.
Well, thank y'all so much for joining us.
Thank you for having us.
Thank you for having us.
So let's just start, Stephanie. What is the Transitional Care Unit? I mean, let's just get some basics going, because some people are probably watching this and are like, I don't even know what TCU stands for.
Sure. Yeah. So, you'll hear TCU a lot because it's a lot less of a mouthful than Transitional Care Unit at Russell Medical. Mm-hmm. So we are a post-acute rehab unit. So we provide skilled nursing care and skilled therapy care for patients, usually after an acute stay at the hospital, when they need to regain strength and balance, endurance, things like that, before they return home or transition back to their normal environment.
So what kind of services are we looking at then at the TCU?
They have a nurse with them 24/7. You've always got a nurse, so we can provide skilled nursing care like IV antibiotics, breathing treatments, other medications. So we do that sometimes, but most of the time it's about these guys. I mean, they do our therapy and they help really improve the outcomes for those patients.
So Bailey, tell me a little bit about how physical therapy in the hospital setting, how does that help a patient to get back to normal?
Okay, so for TCU rehabilitation,
I can't hear you.
Oh, okay. Usually for physical therapy, our main focus is to evaluate the patient and day one.
We're still having trouble hearing.
Oh, okay. I'll get a little closer.
There you go.
Usually what we usually do is evaluate the patient day one, what their deficits are, what we need to do to get them home or to assist living or back to living with a family member or whatever they're going to do for functional mobility, stimulation, using an assistive device, training with that assistive device, toilet transfer, and even getting in and out of a car so they can face the home appointment. So, and we, have kind of needs maybe a ramp into their home. So, just because they're safe, have good activity tolerance, balance, what kind of needs they will need, like equipment they will need when they go home, or if they need someone to stay with them afterwards when they return home, a family member or a sitter.
So Stephanie, she broke up a little bit there. So give me a little synopsis.
Yeah, so they do evaluations on those patients once they're admitted. Usually first day they come in. So they are helping assess their abilities to do different tasks, such as bed mobility, getting up and walking in the hallway, even getting in and out of a car, and also assessing for what kind of assistive devices they may need. And that's where I'll help to get equipment set up for before discharge. And also if they're, safe to be by themselves, or if they're going to need a family member or sitter or some other kind of caregiver to be with them.
Mm-hmm. And then what is the difference between physical therapy and occupational therapy?
So occupational therapy, we're going to focus more on things that you need to do every day or want to do every day. So getting up, getting dressed, brushing your teeth, going and taking a shower, going to the bathroom. cooking, cleaning, driving, all of those sorts of things, or even hobbies, or even return to work. If you've started babysitting your grandchildren, that's all part of that. So anything that you need to do functionally throughout the day, that's what occupational therapy is going to work on.
Awesome. And so you guys are giving how much therapy in the TCU unit daily?
So physical therapy, you're going to be seen twice a day, once in the morning and once in the afternoon. Usually one of those is a 45-minute treatment and the other is a 30-minute treatment. And then occupational therapy, you get seen once a day for 45 minutes. And it just kind of varies. We try to get you in the morning so we can get you in the shower and get you dressed and things like that.
It does depend on the need of the patient. You know, we have the ability to see that.
I cannot hear Bailey at all. I don't know. It must be the way that the microphone is.
Maybe the way I'm sitting.
Yes, there you go.
The time depends mainly on what kind of functional needs they will need to go home. Like if we have more time to spend with the patient, then we can work on those skills so that they're safe to return home. They have better balance. Their their endurance is better. It's their need over, so that they're safe to return to pro level.
And we're seeing these patients 6 days a week, 5 intensive days, 1 day on the weekend, and then a rest day. So that kind of helps.
And then on top of them seeing them, Stephanie, they're also seeing nurse and.
Mm-hmm. Yeah.
Okay.
And then,
I can't hear you now, Stephanie.
oh goodness!
I think it must be
maybe the angle of the microphone. I don't know.
It's got to be the angle of the microphone.
Yeah. So Dr. Goldhagen is over our program, and she does, a great job of helping see after these patients and make sure that they get the care that they need. We're transitioning the type of care from an acute care where you're getting seen every day by a doctor and having all these changes in medications. We're wanting to get it back to transition to back home, hopefully. So that's our goal. And so you don't see the doctor as much. They're always here in the background. And the nurse practitioners are over that program as well. So they're always here, and that makes it good for our unit being in the hospital, as we've got somebody here 24/7.
Yeah, that's awesome. And it just kind of gives a nice kind of slope down to going home instead of just kind of a drastic drop.
Yeah, and we start planning from the first day. It always confuses patients when I go in and I'm like, okay, when you go home, what do you think we're going to need? I want to know from you guys, from the family, friends, or somebody visiting, what do you feel like your loved one's going to need, and what the patient feels like they're going to need? And they're like, well, I'm not getting out of here for a couple weeks. I'm going to be here. I'm like, I know, but we start thinking about this from the beginning. That way we have time to plan all that out. Because sometimes, unless you bring it up, patients don't think about it. And all of a sudden,
so fast.
Yeah. And all of a sudden they're like, oh, well, I got to be able to climb 4 stairs to get into my house. So those are things we've got to work on.
Absolutely.
You have to also be able to assess their environment they're going to. So, we'll have to discuss the steps. We'll have to discuss drugs in their house. If they have dogs, that's a fire hazard. If, they have to step over into a tub, if it's not a walk-in shower, they need a shower chair or bedside mode. Those things need to be addressed before day one so that we can order these things or contact companies there. And we also do meet with all the disciplines involved. We do that once a week. We have a meeting that we discuss any types of needs the patient needs, any concerns, how to change treatment, what goals need to be addressed too.
Awesome. So a lot of times I get the question from a client, they're in the hospital, they're ready to go home. They don't want to go to rehab. They just want to go straight home. What's the difference between going to rehab and just going home? And I mean, you guys hit it on the head with this intensive therapy. You're not going to get that at home. You're not. I can have a caregiver there to read out your exercises, and it is night and day from having a therapist next to you. It is not the same thing.
Right. And here at Russell Medical, we have a huge gym. I mean, they've got so much more they can work with versus what you have at home, maybe some hand weights or something. That's about it. So you've got so much more you can do while you're in a unit like this versus when you're at home.
Yes.
And we also have an ADL room where they can practice cooking, they can practice cleaning, there's a bathroom, a shower bench, a bed, a standard size bed that doesn't, have rails like a hospital bed, refrigerator, just the whole setup like in a small apartment. We can practice the home environment. And then we have a car simulator. It's mostly to practice with transfers in and out of the car. So
you have to think too, when you go home, how's your caregiver going to help you? Are they going to help you get dressed? Are they going to help wipe you when you go to the bathroom? Sometimes you don't want your son or daughter helping you out with that.
Absolutely.
And so that's where we come in, is we can help you maximize those days in the rehab stay so that when you go home, you're able to do that independently or as close to independently as you can.
Yeah, absolutely. So, Stephanie, what are some misconceptions or confusion that comes up for people with rehab? Like, what are the big things that people are scratching their heads and they're like, I just do not understand this?
A lot of times with us being a unit within a hospital, people feel like they are still in the hospital. They're wanting to know, well, what are we doing about this pneumonia? And it's kind of, we have to take our time and explain that to patients to say, okay, we're done with the hospital stay. We are continuing to treat your pneumonia, but it's not going to be, this is solved and you're going home today. We're going to plan this out, and this is a process. And the goal is for you to be more independent. So we take a step back and let a patient try for themselves more. And then we're there to help them versus doing things for them. Not because we don't want to do it, but because our goal is to make you more independent. It may take us longer, but we're going to build that endurance and strength and get you back where you need to be.
Yeah.
And another misconception is, if you see bed or care, you say, oh, well, it has to be the 21 days. You have to stay a full 21 days. That's not the case. You have a patient that they only need maybe 20% of assist, from inpatient. They just need a little help getting up, just a little help walking down the hallway. They're probably not going to stay for 21 days. They may do 10 days, maybe 14 days. They may have a caregiver that help with caregiver training. So it does have to be the full 21 days.
Yeah, and really it's based on need, right?
Right. And we do caregiver training as well, because, sometimes it's a patient that maybe they've had a break in their leg and they can't bear weight on it. And so they really need help of learning how to get their loved one out of the bed into the commode and things like that. So, we've got a range of stay for patients from 5 days to, some over 21 days, which our goal is to not go past that. But it happens sometimes, but usually we stay around 14 days.
Yeah. So you mentioned something earlier about, the first day you're in there asking, okay, so what are we going to do when we get home? So my favorite phone calls are Thursday evening. Mom's coming home from rehab tomorrow. We're going to need caregivers. And I'm like, wow.
Right.
Tomorrow.
Yeah.
Let's talk about that transition home, because I think a lot of times we forget that transition is just as important as the rehab.
Absolutely.
And we can pull some bounce back rates and stuff. But especially if you've gone into rehab because of a stroke, because of a heart attack, because of a fall, going back from one location, going from, having that weakness and maybe not full stability to a home environment that is different now for you, the chance of you getting re-injured is so much higher if you're not prepared.
Right. And I even will talk to patients, if they're here in the hospital and thinking about coming to the transitional care unit, I'll go see them before and I'll say, okay, when you go back home after rehab, what's the plan? And like you said, I mean, people are just, that's a long ways away. Why are we thinking about that? But it's because it's very, very important that you have a support system and that you have help. Okay, maybe you've got 3 daughters that live in the area, but they all work full-time jobs 8 to 5.
Right.
Who's going to help you during that time? And
Yeah,
do you have everything you need?
Exactly. A lot of times people will say to us, well, that's in 2 weeks. I don't know what abilities I'll have in 2 weeks. But the reality is you kind of know the projection. And what I always tell my clients is, let's start off with maximum care, or let's just make sure that somebody is with you, even if it's not us. Like as long as you have a spouse with you, or, son is staying the night or something, until you get home and we feel comfortable, and then we can easily taper off. We're not what I love about my transitional cases is I can go in and say, so in a couple of weeks, you're going to fire me and tell me you don't want to see me again. And I love it.
Yeah, that's what we tell patients. We'll see you like in Walmart or something, hopefully not back in the hospital.
Yes.
Right. And yeah, that transition, your preparation can happen so much sooner than the day of discharge, and I tell patients all the time, it's even just with home health, they're like, I don't know if I want them coming in, but I have somebody that, they can come and see you. But then if you don't need them, they don't have to keep coming.
Right.
Yeah.
And we do our best too, while in rehab, to make that transition as seamless as possible. If you have a tub that you have to step over, that's what we're practicing that. If you have stairs to get into your house, we're practicing that. If you don't have a trapeze on your bed, guess what? We're not going to use the trapeze here. We're going to lay your bed flat, just like it is at home, to try to simulate this thing, to make that transition as best as possible. We even make sure you're on your home medication, not the medicines that you just started. We want to make sure that, yes, you continue those, but this is what you're going to go home with, and this is what it should be every day.
And
so
that's
we're trying to make that as easy as possible.
I mean, there are more falls and stuff that happen just from medication mismanagement. And, if you've ever had, a loved one in the hospital, they come home with like 10,000 more medications and they don't understand when to take them, or, so one of the first things we say is like, we're going to push you to have that primary care follow-up. Like, we need to see every single pill that you were placed on and go over it with a fine-tooth comb. So I love that you guys are already addressing that in TCU and rehab, because that's huge. I mean, that makes such a big difference to go ahead and start that before you ever get home.
Right.
Exactly.
So awesome. Any advice or tips that you guys would give somebody who maybe is watching and has a loved one that is going into rehab, or has pushed back on going into rehab? Or...
Well, I'll tell you, if you feel like your loved one needs rehab, it never hurts to ask. I don't mind the phone calls at all that say, hey, my mom's at home. I want to know if she qualifies, because every insurance is different. Every insurance is different. Approval processes, a lot of times people hear about that 3 midnight rule, and that's true for, regular Medicare of being an inpatient in the hospital for 3 midnight. But for a lot of, other plans, it's not the same. It never hurts to ask, never. And we just always push about, you don't always have to stay the full 21 days. Like I said, we've got people who stay 5 to 7 days or 10 to 14 days, So it never hurts to ask. And usually the ones who fight it the most love these people before they leave. And they're like, I'm coming in for outpatient because I just love everybody in the therapy department. So people love it. And we've got some great nursing staff, the staff there, they really fall in love with these patients, because, you have them there for a little bit longer than that 2 to 3 days like you're in the hospital. You really get to know these people, and we get to enjoy your hobbies and find out, that you love to color, or you love to crochet, or you love to paint your nails. I mean, you get to know these people more.
Yes.
And it's not just, like I know it, that a lot of patients, like, oh, I'm in the hospital, but the easy part of it is that you go just on the hall. Right. You don't have to be put in a car, to be transferred across town, to be exhausted when you don't feel well. You're just on the hall, where you have nurses that are used to acute care settings. They work inpatient too. some of these, I mean, we do have to use specifically nurses, but it's a situation where that transfer from acute care to TCU is much easier.
Yeah, and I love that because you are within the Russell system, that if you have seen a provider in Russell, if you were in the hospital at Russell, then all of your medical charts and what, it's
All
with
those
you.
records. Yeah.
And I love that because, I know, Stephanie, you've worked in case management forever, and I have coordinated with case managers, and to get records from like a hospital to a rehab to, just is a nightmare. And so just to have it at your fingertips, and, you do get sick, or maybe something happens to you while you're in rehab, God forbid, then it's already there.
Right.
That provider network is such a huge part. And I'm sure that was part of the thinking when they put TCU together. But it's been such a good thing for our community. And I really wish more people understood what the TCU is. So if they're in the hospital, can they request to go to the TCU and not to a different rehab facility?
Absolutely. Just talk to your discharge planner. And even if, nobody's even brought up rehab, if you think that there's a possibility you may need it, sometimes that's all it takes is you saying, hey, I think mom might need to go to rehab, because maybe they're focused on something else. Maybe they got a cellulitis or something, they're focused on that and haven't really thought about that this is a debilitation from where they were before.
Right. Yeah, and I have called more than once, Stephanie, to say, I really need you to take this patient. I really need you to take this patient. Like, I need you to make sure that you can take this patient.
Right.
and we take patients from other hospitals as well. Sometimes we'll take them from home or home health. Like Stephanie said, it just kind of depends on your insurance and your situation and what's going on. But it doesn't hurt to pick up that phone and call Stephanie just to make sure. Going on the things that you were saying, you wish people knew, please pack clothes.
Oh, yeah, pack clothes.
We're going to get you dressed every day. We're going to take you down to the gym. It's like we said, it's not like being in the hospital, even though you're on the same floor. Bring your toiletries. We're going to get you up and going, and we want you to feel like a normal person.
Yeah,
that's awesome.
Comfortable shoes, non-skid shoes. Nothing is about slippers.
Yes, so good. Yeah, and Kelly, I like what you said, because a lot of times somebody may be in the hospital at UAB, or especially right now where beds are limited, they may be in Montgomery or at Grandview or whoever knows. But when it's time to transition to a rehab unit, call Stephanie, because even though you're in those facilities, if your home is Tallahassee County or Lee County or, even Talladega County, you're nearby, like call, because that's such an easier commute.
Yeah.
Lakeshore, Encompass Lakeshore, or, those are great facilities, but you're talking 2.5 hours.
Right.
Yeah.
Right.
That's tough. So, well, ladies, I really appreciate your time today. Is there anything else that you think that anybody who's watching or will look at the replay would be interested in hearing about?
One thing I wanted to bring up is if you're planning a surgery coming up, if you're, having a hip replacement, knee replacement, we love orthopedic patients. If you have one coming up and you want to call and talk about rehab before you're in the hospital, that's a great time to talk about it when you're not having to worry about your pain or your anesthesia, a little loopy. We can talk about it and plan before you even go in for that surgery. And that also helps us to be able to talk about things that may need to change at your home while you're in rehab. Maybe they need to build a ramp or kennel the puppies or something. Just think about those things ahead of time.
Yeah, that's great advice.
Yeah.
Anything else you ladies want to add in? Oh, get closer.
Oh, I'm sorry. We would love to have anybody that's interested in, any type of rehab to return. You want to feel safe and have good balance during going home alone. And usually the patients that, most often the patients we have are the ones that will return home alone, and they need to be as independent as possible. So we a lot of those patients, and if you know that's what you're you have to return home with maybe just somebody coming in and checking on you. That's one of those things that we want to make sure you're safe with.
Yes, that's when you call Beyond Home Care.
That's right.
And we'll stick with you for a couple weeks, and then we'll say bye.
Yeah. Yeah, we
Well,
appreciate you very much. I know that you come and talk to patients a few times. I've even used your words sometimes talking to people about, a spouse being a caregiver versus having someone else be the caregiver so you can be their spouse.
Yeah.
I've said that before to patients after I've heard you talk about it. That's a great way to put it,
Yeah.
So we appreciate all the help.
Like Kelly said, I mean, you may not want your son wiping you,
Right.
that might, that may be, that's okay. For us, that's normal. That's what we do every day. So it's not a big deal. Utilize your resources. It's not forever. And that's what people need to understand. Like, yes, this is a long, it feels like, oh, we're going to go from hospital to rehab, and then we're going to have home care and home health. But in the long, view of it all, this is small. This is so that you can have long-term success and not, get back to that ability that you had before and not continue to re-injure or continue to get ill or, so. Well, that's awesome. Well, guys, I really appreciate it. Stephanie, Kelly, Bailey, thank you so much for joining us today. Guys, if you have any questions about I see I'm doing it again. I was going to say total healthcare. I've got to get total healthcare off my brain. About the transitional care unit at Russell Medical, please give Stephanie a call. And it is Rehab Awareness Week and Celebration Week. So if nothing else, you can give her a call and just say, hey, we appreciate you and everything you do. And you will not meet a nicer person than Stephanie. So pick up the phone and, ask her questions because she's going to answer them for you.
Sure.
Yeah.
All right, guys. Well, y'all have a great rest of your day. Thanks again.
You too. Thank you.
Bye.
Bye.